Hello, my name is Thomas Baker. I will be conducting a secondary assessment. I'm going to start my secondary assessment with the following history intake. I'm going to use the OPQRST, onset, when did it start, did it come on sudden or gradual, what provoked, what brought it on, anything make it better or worse, and the quality. Describe the pain to me, any changes since it began. Radiation. Can you point to the pain? Does it move anywhere? The severity. On a scale 1 to 10, 1 being the least, 10 being the most pain you ever had, what is your pain level? And time. Is the pain constant or does it change? Any treatments? Have you taken anything prior to calling for EMS? Then we're going to move on down to sample history. We're going to look for signs and symptoms, what the patient's experiencing. Does the patient have any allergies to meds, food, or anything else? Does the patient take any medications, RX, over-the-counter meds, and when was the last dose you took? Past medical history. What kind of surgeries did you have? What kind of past medical history do you have, such as diabetes, cardiac problems, seizures, and so forth? And any similar episodes to today's events. When was your last oral intake? What was it? And approximately what time did you eat or take something? Events leading up to now. So what's been going on that made this worse to call EMS today? Then we're going to look at habits around the home, such as drug use, alcoholism, tobacco. We're going to look at the patient's environment, what's around the patient and how their living style is, and what is their risk factors. Then we're going to get a little more detailed, assess the brain, lungs, and heart. Then we're going to move down to the eyes, nose, and throat to make sure everything is good there. We're going to take a closer look at the neck for the jugular vein distension, whether they're going to need C-spine. We're going to assess the C-spine and determine whether there's any crepitus or anything there, and make sure the tracheal is midline. Then we're going to move to the pulmonary section. Listen to the lung sounds front and back, starting at the patient's right and back and forth. Then we're going to move into cardiovascular. Listen to the heart tones in S1, S2, and the apexes. We're going to perform pulse motor sensory in the hands and the feet, check capillary refills, and check the ankles for repeated edema. We're also going to check the pulses, the distal pulse in the foot and behind the ankle as well at the same time for equality. We're going to check the skin conditions again and any pelvis problems, orthopedic problems at that time. Then we're going to move into the neuro. We're going to do a stroke scale. Any numbness or tingling anywhere, then I will check the cranial nerves, starting with the olfactory as smelling, optical. I'm going to do the visual fields in their peripheral vision, oculomotor, trochlear, and abducens. I'm going to have them stare at my nose and do an H pattern to check those nerves. Trigeminal, we'll feel the face from the forehead to the chin, and then I will ask them to bite down. In the for the facial nerves, I'm going to have them smile, frown, puff their cheeks, wrinkle their forehead, and squint their eyes. Autistic, I'm going to rub fingers near their ears to check that nerve. Glossopharyngeal, I'm going to ask them to swallow. And at the same time, I'm going to check the vagus nerve and ask them to gag. Spinal accessory, I'm going to have them raise their shoulders, look left to right. In the hypoglossal, have them stick out their tongue. Then we're going to check the vital signs for temperature, pulse, respirations, BP, O2 sat, glucose, a CO2. At that time, we're going to hook them up to EKG, reassess the skin, temperatures, and Hager, reestablish the LOC, and reevaluate the eyes for pearl or unequal. Field impression is going to be our next thing to do, differential diagnosis, what might be going on with the patient. Then we're going to come up with a treatment plan, appropriate intervention, perform treatments in an organized, timely manner. Then we're going to reevaluate the transport decision, whether we need to step up our game or keep traveling the way we are. At that point, we're going to reevaluate the primary survey, take another set of vitals, and evaluate response to treatment. What treatments we've done so far, is this helping the patient? Then we're going to give a verbal report to medical command and to the ER nurse physician, and then give an effective domain of the patient, what's helped from the start of the call till the time we arrive at the emergency department.